Hello everyone, welcome to class. I'm very excited to get started with this. I hope you all were able to do the discussion board and post a little bit about yourself and then comment on two of your classmates. I reviewed some of them and looking forward to getting to know each of you. I know we only have a 2 hour class, so I do appreciate you guys putting your phones away, paying attention. Just phones on silent. If you need to take a call, you can just step out right now. You can just step out to take that call. But otherwise, let's get started. Feel free to raise your hand, ask any questions throughout the presentation. We're going to first do a lecture. I have some PowerPoints here that we're going to go over, and then after that, we will do a Kahoot, which is it's an online like survey type questions that you guys can use your phone to answer them. There's no pressure here. This is not graded. It's just kind of to see how you guys grasp the material. And we're also going to go over the two articles that I asked you guys to review before coming into class today. Okay, so let's get started with breast milk fortification. We can't talk about breast milk fortification without talking about breast milk. Um, so the first milk that is produced by a mom is colostrum. This is not a large amount. We shouldn't be expecting more than a couple cc's a day from a mom. Sometimes they'll get up to 20. But this is very rich milk. It's golden. It's got that color, but it is so high in antibodies and all good fats for the baby. That's why they don't need too much of it. And it is actually something, so when they say it lines an infant's gut, premature babies especially, so moms, based on what their gestational age is, what their baby needs, they will produce more of what they need. So if you have a premature baby, you're going to produce more protein, more antibodies, more fat, because that's what your baby needs. So when we say it lines the infant's guts, premature babies have a much more permeable intestinal lining, and that puts them at greater risk for something called necrotizing enterocolitis. It could be common in infants. It could be, sometimes it could just be treated with antibiotics, and other times it does require surgery, which will involve generally an emergency Penrose drain placement at the bedside and eventually have an ostomy for these babies. It is very much life-threatening situation. So having this that coats the the intestinal lining is a very big thing for babies and is very important for them. Um, so moving on. So concentrations of components of breast milk. So like I said, premature versus full term, they're going to have, just higher concentrations of just about everything. What's involved in breast milk? We have the little picture in the corner, but protein, the main things: protein, calcium, sodium, magnesium, phosphorus, potassium, different hormones, antibodies are very important, carbohydrates, amino acids, water is part of it as well. It is a liquid. Um, so, like I said, that date based on when your baby's born and what your baby needs will be the amount of the actual concentrations. We can't, it's not like we take your breast milk that you pump every day and test it for the different concentrations. These are all guesstimates, but we do know based on different studies that, let's say, a mom who gives birth to a 23-week baby versus a mom who gives birth to a 36, 37-week baby, that mom with a 23-weeker will have much higher proteins in her breast milk as well. Breast milk, especially in the premature baby, has shown to have these babies are shown to have increased weight gain, increase a faster growth rate in their length, in their head circumference, their neurodevelopmental factors. Um, and then from colostrum, we move on to transitional milk, which is just like it's named. Your milk is transitioning from colostrum eventually into mature milk. But with transitional milk, will also have like the higher calorie and fat content, whether you're full term or premature. However, premature will have some more. And the mature milk is a much more stable milk in terms of their concentrations. They're not going to fluctuate as much. They will still might, fluctuate in small ways, especially, if the mother is sick, her breast milk will actually produce more antibodies based on also what she eats. There might be, small variations in the different vitamins and minerals that are in her breast milk. Okay. Now, when we talk calorie content, so this says calculations, but let's look at that first bullet point, which says calorie content. Breast milk generally at its base, like I said, we don't test it every day. We can't give an exact number. However, generally pure breast milk is about 20 calories per ounce. So an ounce is 30 mLs. So 20 calories. So a full-term baby generally requires 100 to 120 calories per kilogram per day. A premature baby can be anywhere from 100 to 150 calories per kilogram per day. Usually when a premature baby is born, they will start out with, a 10% dextrose, and then in the interim, and then generally by within the first 24 hours, they will be placed on total parental nutrition, or TPN, and also intralipids as well. So this TPN will have, vitamins, minerals, will have protein, fats, dextrose, everything that that baby needs. Generally, we'll start that anywhere from 80 to 100 calories per kilo per day, and then they will increase it. Once feedings occur, what they will do is they will actually they'll start the feeding at, let's say, 10 to 20 calories per kilo per day, go down on the TPN as they increase the feeds. So for a premature baby to get off of all fluids, IV fluids is what I mean, they'll generally be in the 130 to 150 calories per kilo per day. And at one point, they will most likely end up at that high end of 150 calories per kilo per day. And then as they see, the nutritionists and the doctors will look at the baby's growth curve. As they see that they are sticking with that growth curve, they will slowly bring them down. And generally, most babies will go home with, instead of having to reach a specific volume before they leave, they'll have a minimum that they have to take, and they can take a little bit more than that. We'll talk about this a little bit. We'll talk about this more as we go, but I want to talk about calculations now. So now talking about plain breast milk, we're not talking fortification yet, that's on the next slide. So plain breast milk, if you have a 2-kilogram infant who feeds 8 times a day. So let's say we're at that top end of 150 calories per kilogram per day. So 150 times 2 kilograms is 300 calories per day. That's divided up into 8 feedings. So that's 37.5 calories per feeding. So now you want to divide the calories per feeding by the calories per ounce. And this is where we get the 37.5 calories divided by 20 calories per ounce. That baby has to take 1.9 ounces, which is 56 mLs per feeding. Now, a 2-kilogram baby is roughly 4.4 pounds. So we're taking almost 2 ounces in a very tiny baby, less than 4.5 pounds. So that's 8 times a day. So this is, a lot of milk. So let's go on now, and we'll talk about fortification and why we do it. So by using fortification, we can increase the nutritional intake that the baby is feeding without increasing the volume that they're feeding. Because like we said, a baby that's 4.5 pounds taking almost 60 mLs every 3 hours is a lot of milk. That can cause distension, that can cause them to have the vomit, in which case they're not really taking in anything. So that's why we're talking fortification. So there's 2 different types of fortification. One of them is called human milk fortifier. So human milk fortifier can increase your calorie content to 22 calories per ounce or 24 calories per ounce. You can even go higher to 27 and to 30 calories per ounce, but we're just here going to talk about the 22 and 24 as those are the most commonly used on our unit. The human milk fortifier is only going to be used in hospital when they are an inpatient. And this should not be started on a baby until they are tolerating their feeds completely. Now, they don't have to necessarily be up at that 150, but they need to be in the 120, 130, and almost completely, if not off IV fluids. So that means the baby should be able to take that breast milk 20 with by themselves, whether it is, we're going to be talking in terms of babies that are taking the feeds completely by bottle, they're POing everything. However, these babies can sometimes be just taking enteral feeds through an NG tube or an OG tube, but we're just going to stick with the PO feeding for right now to not get confusing. So they should be, taking their full feed so that we know that they can take, let's say 56 mLs, but maybe a little less. Maybe they're taking 40 mLs and they're able to tolerate it. They're not throwing up because of the 40 mLs. They're not having abdominal distension. They're not constipated. These different things we want to know they are able to handle and tolerate on full feeds of just plain breast milk 20. And then we will go to a higher 22 or 24. We will always just fortify to 22 calories first. Make sure the baby can tolerate that for 2 or 3 days before going up to 24 calories if they need it. Not all babies need to go up to 24. And then we're going to monitor for any feeding intolerance, just like we would with the full feeds of the 20 when we get to the 22. And then if we need to go to 24, looking for any abdominal distension, any discoloration in the abdomen that looks like a lack of blood flow for whatever reason could be, vomiting, or just not wanting to take their feeds anymore. So now the other type of fortifier is the powdered milk fortifier, which is powdered formula. Um, we're going to be talking in terms of the Similac Neosure powder, the 22 calories, the yellow tin, which we have photos, and the Enfamil Enfacare, which is a greenish blue bottle. But again, we have photos and we will get to it. These can also increase breast milk to 22 calories per ounce and 24 calories per ounce based on the mixture. This will be used second, so generally we'll use human milk fortifier or HMF first, and then we will transition the baby to a powdered fortifier. The reason that they'll go home on this is because this is something that is readily available to parents. Human milk fortifier is not something that you can just go to the grocery store and buy. The powdered formula is. Again, when we switch between the human milk fortifier and the powdered milk formula, we will monitor for any feeding intolerance. Again, vomiting, abdominal distension, constipation, discoloration in the abdomen. Many a times, a baby who goes home on fortified breast milk will likely use this until they are roughly a year old, until they're done taking the milk, unless directed by their pediatrician. Sometimes babies they will catch up very quickly and they will be exceeding the growth chart. That's going to be based on the pediatrician and will be once they leave us. That is not something, if they are being fortified here, 9 out of 10 times they will go home on fortified breast milk. So that's why we're doing this, so that you guys are able to learn and understand why we do this, and then you're able to explain it or teach it to the parents. Fortified breast milk, by fortifying your breast milk, that should always be initially discussed by a medical team member, whether it is the doctor or the nurse practitioner taking care of that baby. However, parents always have follow-up questions, and sometimes you are the person that has that follow-up question. So you have to be able to answer it. While there are some things that are out of our scope of practice, so the doctors will have to come back, you should be able to speak to this and also speak to how it will be done. Us or nutrition will be the ones who will teach the parents how to fortify breast milk, so we need to be able to do it.